You sit in the waiting room, they call your name, and before anything else happens, you're asked to step up onto the scale. That familiar clang of metal sliding into place has been the starting line for medical care for a century, spitting out a single number that defines how the medical system sees you, your body mass index, or BMI. For decades, this mathematical equation, your weight divided by your height squared, acted as a strict dividing line. It determined whether your chart read healthy, overweight, or obese, triggering different treatments, impacting insurance coverages and lifestyle assumptions. But there is a glaring biological blind spot baked into the math. BMI cannot measure body composition. It treats 10 pounds of dense muscle exactly the same as 10 pounds of adipose tissue. A competitive athlete and a sedentary office worker can share the exact same BMI, despite having distinct physiological profiles. The formula also assumes a universal human biology, ignoring racial variation. Because different populations distribute and store fat in different ways, standard BMI thresholds underclassify the risk of heart disease and type 2 diabetes in Asian and Black individuals. This leaves millions vulnerable to metabolic conditions, while their chart says they are healthy. A normal BMI can hide lethal organ fat, and a high BMI can exist in someone who is metabolically thriving. Because of this, the global medical community is pulling back from the scale. They are officially redefining obesity as an adiposity-based disease. This clinical workflow represents the new standard for diagnosis. The initial screening and confirmation steps prioritize multiple markers alongside BMI. Doctors now use BMI as a trigger for further testing, supplementing it with waist circumference and the waist-to-height ratio, or WHTR. This ratio is calculated by dividing your waist circumference by your height. If that resulting number crosses the threshold of 0.5, contemporary guidelines flag it as a risk indicator for cardiovascular and metabolic disease. The focus has shifted to the waist because location matters. Subcutaneous fat, sitting just under the skin, is relatively inert, but visceral fat, accumulating deep inside the abdominal cavity, is biologically active. It wraps around internal organs, releasing inflammatory markers that disrupt your metabolism. Modern screening prioritizes these immediate biological threats. The critical medical question is no longer how much do you weigh, but rather where is your fat located? If waist measurements indicate a high concentration of central fat, the clinical pathway moves to confirmation. Doctors must look inside the body to verify the volume and distribution of that adipose tissue. They have several options. Bioimpedance scales run a mild electrical current through the body to estimate fat percentage. In clinics, DEXA scans provide precise breakdowns of bone, muscle, and fat mass, though they expose the patient to a small amount of ionizing radiation. The gold standard for confirmation is the MRI. It eliminates radiation risk while locating ectopic fat, the lipid deposits hiding inside the liver and heart. By deploying this imaging technology, physicians separate the outward appearance of a patient from the active biological hazards developing underneath. Which brings us to the most significant shift in these guidelines. Under this modern framework, carrying excess body fat no longer leads to an obesity diagnosis unless that fat is causing bodily harm. Clinicians evaluate this damage across specific domains. The first is cardiometabolic harm. They look for abnormal lipid profiles, hypertension, or indicators of type 2 diabetes to see if the excess adiposity has compromised the vascular and metabolic systems. The second domain is biomechanical damage. This covers the physical toll weight places on the body's structure, manifesting in conditions like osteoarthritis and sleep apnea. Clinicians apply frameworks to stage severity. This table compares EOSS and AAC criteria. Stage 1 indicates excess adiposity without functional impairment. Tracing down to Stage 3 reveals severe end organ damage. This exact stage determines the treatment plan, from behavioral changes to GLP-1 medications or bariatric surgery. A diagnosis is no longer a measurement of how much fat exists on a frame, but an assessment of the damage that tissue inflicts. Implementing this new multi-step diagnostic system is difficult for primary care doctors, facing time constraints and limited specialized training. These advanced frameworks demand robust resources. They require routine laboratory testing, functional assessments, and the integration of complex diagnostic data into electronic health records. This is a heavy administrative burden compared to the historical ease of glancing at a laminated BMI chart on the exam room wall. Yet, as this research outlines, the goal is to transition the medical system from a weight-centric model to a complication-centric model. The era of judging human health by a number on a scale is over. By focusing on biological harm rather than physical size, medicine is finally treating obesity with the precision required for a chronic disease.